Hello, I'm Dr. Stephen Reed, President and founder of Doctor Lifeline Incorporated. I'd like to introduce you to our organization and our mission to prevent physician suicides. Dr. Lifeline is a nonprofit Florida corporation with 501c3 status from the IRS. This means any donations to Dr. Lifeline are 100% tax deductible. Most people are unaware of the serious problem of physician suicide in the United States. Doctors kill themselves at a rate higher than any other profession, higher than active duty military, dentists, and even higher than U.S. prisoners. Something's terribly wrong with our system. As noted by Talbot and Dean, physicians are killing themselves at an alarming rate. About 400 doctors per year die of a fatal but largely preventable malady in our country, suicide. That's 3 times the size of the large entering class at the University of Florida College of Medicine. These deaths deprive about 1 million Americans of their doctors annually. Almost every practicing physician personally knows one or more colleagues who have taken their own lives. What's wrong with our doctors? Why are they killing themselves? Suicides occur at a rate of 12.3 per 100,000 per year in the general public. Among veterans and military, they occur at 30 per 100,000 per year. Doctors take their own lives at an alarming rate of 40 per 100,000 per year, the highest of any profession. The suicide rate among male physicians is about 1.5 times higher than the general male population. Among female physicians, the relative risk is even more pronounced at approximately 2.3 times greater than the general female population. Suicide is the second leading cause of death after accidents for young doctors between the ages of 24 and 34. Toxic practice environments are killing our doctors. Toxic practice environments are multifactorial in origin. The end result of these multiple factors results in a state of debility, dependency, and dread in the affected physicians. We do not have time in a brief presentation such as this to cover all of the factors. However, we have selected a few important ones to focus on at this time. Hospitals and clinics are remarkably dangerous workplace environments. According to the Occupational Safety and Health Administration, each year nearly 2 million U.S. workers report having been victims of workplace violence. Significantly, research indicates that nearly 75% of all workplace assaults happen in the healthcare industry. In fact, healthcare accounts for nearly as many serious violent injuries as all other industries combined. Approximately 80,000 U.S. healthcare workers are viciously assaulted each year. This contributes to a sense of dread upon approaching the practice workplace. In January 2022, burnout becomes an official psychiatric diagnosis. The ICD-11 will recognize it as including feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativity or cynicism related to one's job, and reduced professional efficacy. In the 1970s, burnout was a slang word for end-stage drug addiction. The psychologist Herbert Freudenberger overheard the word while volunteering in a New York City free addiction clinic and used it to describe himself and his staff in a 1974 article about long-term physical and psychological stress. Its first public application to physicians occurs in American Medical News in July of 1981. Surveys have shown the incidence of burnout has increased from 45.5% to 54.4% between 2011 and 2014. We will now review some very interesting statistics from the Medscape 2019 Burnout, Depression, and Suicide Report. The survey included 29 specialties. As expected, burnout tended to occur in the more stressful specialties more frequently. Interestingly, among these specialties were the physicians least likely to seek professional help, especially in urology, neurology, physical medicine and rehabilitation, and general surgery. The survey confirmed a higher burnout rate among female physicians, corresponding to the higher rate of female physician suicide. In response to the question, "What contributes most to your burnout?" respondents complained of too many bureaucratic tasks, spending too many hours at work, increasing computerization of practice, and lack of respect. The physician's work setting did not appear to make that much difference with regard to burnout. Office-based solo practices had a burnout rate of 41%, whereas healthcare organizations had a burnout rate of 49%. "53% of surveyed physicians felt that depression affected their patient care. 14% indicated, 'I might make errors I might not ordinarily make.' 16% indicated, 'I express my frustration in front of patients.' 26% reported, 'I am less motivated to be careful with taking patient notes.' And 35% reported, 'I am easily exasperated with patients.' Almost half of the physicians surveyed believed their depression interfered with relationships between colleagues and staff. "21% of surveyed physicians did not answer no to the question, 'Have you ever felt suicidal?' 14% indicated having thoughts of suicide but making no attempt, and 1% indicated, 'Yes, I have attempted suicide.' An alarming 42% of physicians with suicidal thoughts have spoken to no one about their concerns. Nearly half of physicians with suicidal ideation are suffering in silence and do not plan to seek help. Gossip runs rampant in medical communities. That's why almost 1 in 5 physicians has obtained or considered obtaining secret mental health care, usually in a different community or off the books. Most workplaces do not offer programs to reduce stress or burnout. Only 13% of office-based practices offered such programs. Office-based multi-specialty group practices and hospitals weren't much better, at 28% and 27% respectively. About 45% of large healthcare organizations, academic non-hospital groups, research, military, and government agencies provided workplace programs to reduce stress or burnout. However, even in this best-case scenario, about 55% have no program. Physicians in training and in practice are often physically and mentally exhausted. They often endure many hours with no food or water, and frequently are sleep deprived. Such conditions contribute to physician debility. Recognizing this problem, the Council for Graduate Medical Education provided caps for work week hours. As of 2018, shifts are capped at a maximum of 24 consecutive hours of direct patient care, with an additional 4 hours for transition of care. The total work week is capped at 80 hours. These are steps in the right direction, but they do not protect practicing physicians, who often put in much longer hours and who may be required to be on call for weeks at a time. In Japan, a strong work ethic results in the unfortunate side effect of overworked deaths. These are so common that the Japanese have specific words meaning overworked death and overworked suicide. Unfortunately, such conditions also apply to physicians in the United States. The term moral injury was first used to describe soldiers' responses to their actions in war. It represents perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. Doctors often find themselves at the intersection of competing interests. They experience pressure from countless parties with differing agendas and feel pulled in several directions. Administrators and insurance companies try to direct, command, and cajole doctors into actions benefiting the corporation more than the patient. Unfortunately, doctors are dependent on these corporations for their employment and therefore their survival. Guidelines, legislation, and regulations often prevent doctors from doing what they know to be in the patient's best interest. Everyone, including doctors, buys into the image of the physician as being stoic and resilient. Doctors must confront human pain and suffering every time they go to work. Emergency room physicians and surgeons involved in the treatment of trauma are exposed to patients with injuries as horrific as on any battlefield. Battles last for days. Medical careers last for years. Such exposure exacts an emotional toll. The culture of medicine affords low priority to the mental health of physicians. In many medical circles, it's taboo to discuss the physician's own emotional issues. Many doctors have no place to discuss or vent their distress. Our doctors are suffering from depression. Depression generally includes sadness, pessimism, sinking mood, aversion to activity, and loss of the ability to experience pleasure. In the general population, about 1 in 10 males and 2 in 10 females have depression. About 10% of depressed patients attempt suicide. Because of their specialized knowledge, physicians succeed in suicide at a much higher rate than the general population. Psychiatry is not an exact science. Even with psychiatric treatment, some physicians will nevertheless proceed with suicide. Some patients respond well to particular medications, while others prove ineffective. The suicidal doctor may trivialize the depth of his despair and convince the psychiatrist that his depression is not that bad. The psychiatrist may not ask tough questions out of deference to a colleague. The psychiatrist might withhold stronger medications or electroconvulsive therapy because of concerns regarding the cognitive effects on the physician-patient. The depressed doctor may cleverly provide just the right answers to short-circuit cognitive therapy. Reasons like these can result in less than optimal psychiatric treatment for physician patients compared to the general population. Even after treatment, the physician must return to the environment that contributed to his depression in the first place. Hence, relapses are common. So why don't more doctors simply ask for help? They have reasonable personal fears prohibiting this. They're concerned about loss of referrals, loss of reputation, loss of license, and potentially loss of life or health insurance. Some state medical boards publicly report on physicians who seek psychiatric care. Reporting can be interpreted as a form of public shaming. Doctors read these reports like tabloids, hoping that they will not be next. If a doctor's reputation suffers, he or she will lose referrals and their patient base. Should the doctor lose his or her license, they are out of business. Should the doctor seek help for a suicide attempt, they may lose access to health or life insurance. Together, these issues discourage doctors from seeking help when they most need it. These and other rational personal fears contribute to the continuing sense of dread experienced by practicing doctors in the United States. Humans are social creatures. We have inherited hierarchical societies based on dominance and submission. Our feelings of self-worth are based upon where we fall in the hierarchy. Public defeat or humiliation in the workplace results in a loss of social stature. For example, a doctor in group practice may have many good ideas to advance the practice's goals. Her supervisor might feel threatened and therefore belittles or denigrates her ideas. When these episodes occur again and again, they contribute to learned helplessness and an erosion of self-esteem. If the leader habitually adopts such a management style based on dominance, it will contribute to a poor morale throughout the organization. The organization will suffer because many good ideas will be suppressed. Workplace bullying is a common form of social defeat. It can originate with the boss or a coworker. Sometimes it begins with gossiping or backbiting. These are relatively common in medical workplaces. The next stage of workplace bullying usually involves directing the attack to the target victim, usually through verbal confrontations or social rejection. If the situation escalates, as it often does, there may be attempts from the bully to force the victim out of a job. This form of highly destructive subterfuge, unfortunately, is not uncommon in highly competitive residency programs. Each person's self-image depends on interactions with their colleagues. A tarnished self-image contributes to hopelessness and depression. The victim of workplace bullying always has in the back of their mind the fear of economic, career, and future losses. Symptoms of social defeat are similar to PTSD, with depression, loss of self-esteem, anxiety, sleep disorders, and psychosomatic disorders. Social defeat and workplace bullying contribute to dread in the medical workplace. Our physicians are suffering from loss of autonomy. As pointed out by Daniel J. Waters, thoracic surgeon, physicians by nature crave autonomy. We are educated and trained to be independent thinkers, to evaluate, cogitate, ratiocinate, and then make decisions, most of them difficult and often critical. The quantity of misery is proportional to the degree that this hard-won autonomy is taken away. We all have undergraduate and medical doctoral degrees. Many of us have additional master's degrees or even PhDs, plus years of intense postgraduate training and real-world experience. Having decisions made for us by individuals with far less education, training, and experience is more than a bitter pill. Worse yet is the Pino, physician in name only, often a physician who feels compelled to find fault or who sees fit to pass judgment on those who are actually taking care of patients. Learned helplessness may be a better term than burnout for what is killing our physicians. Learned helplessness theory is the view that clinical depression and related mental illnesses may result from real or perceived absence of control over the outcome of a situation. Psychologist Martin Seligman first reported on learned helplessness in 1967. He showed that learned helplessness occurs when an animal is repeatedly subjected to an aversive stimulus that it simply cannot escape. Eventually, the animal learns to stop trying to avoid the stimulus and behaves as if it is utterly helpless to change the situation. Doctors feel utterly helpless when faced with unresponsive administrators, poorly designed electronic medical records, and absurd regulations interfering with optimal patient care. They cannot escape the repeated trauma of dealing with human pain and suffering on a daily basis. They ultimately conclude that nothing they do can make a difference. They either accept the tragedy of their absurd situation, or they elect to kill themselves. As we have shown again and again, debility, dependency, and dread are ubiquitous features of contemporary medical practice environments. Doctors are constantly under the influence of debility, dependency, and dread. The CIA's 1983 Human Resource Exploitation Training Manual, a quote, an interrogation guide, set forth the so-called DDD method of interrogation for debility, dependency, and dread. This publication referred to learned helplessness as apathy which may result from prolonged use of coercive techniques, which result in a debility, dependency, dread state in the subject. I quote from this so-called torture manual. If the debility, dependency, dread state is unduly prolonged, however, the arrestee may sink into a defensive apathy from which it is hard to arouse him. It goes on to say, the purpose of all coercive techniques is to induce psychological regression in the subject by bringing a superior outside force to bear on his will to resist. One of my favorite aphorisms is never attribute to malice that which can be attributed to incompetence. Intentional or not, the system in which our doctors practice seemingly is designed to induce regression in the doctor by bringing superior outside forces to bear on his will to resist. So much so that many doctors can find their only escape in suicide. Now let us summarize the story so far. We've shown that physician suicide is a serious ongoing crisis in America, with about 1 million patients per year losing their doctor to suicide. For a number of reasons, this remains a hidden epidemic. If the public were aware of how precarious the situation actually is, there would be widespread outrage and calls to reform the system. We have reviewed the remarkably high rate of physician suicide compared to the general population and other professions. We have pointed out that suicide is the second leading cause of death for young physicians. We have shown that toxic practice environments subject physicians to debility, dependency, and dread, three elements deemed essential for breaking the will of prisoners interrogated by the CIA. We reviewed multiple statistics comparing practice environments and the availability of programs to reduce stress or burnout. We reviewed several specific elements contributing to burnout and learned helplessness. We pointed out that learned helplessness may be a better description of the plight affecting so many at-risk physicians. So, what can we do? We know that what we are currently doing doesn't work. As Talbot and Dean pointed out in 2018, the simple solution of establishing physician wellness programs or hiring corporate wellness officers won't solve the problem. Nor will pushing the solutions onto providers by switching them to team-based care, creating flexible schedules and float pools for provider emergencies, getting physicians to practice mindfulness, meditation, and relaxation techniques, or participate in cognitive behavior therapy and resilience training. We do not need a code lavender team that dispenses, quote, information on preventative and ongoing support and hands out things such as aromatherapy inhalers, healthy snacks, and water, unquote, in response to emotional distress crises. None of these measures is geared to change the institutional patterns that inflict moral injuries, PTSD, and learned helplessness. Many organizations have begun to notice the prevalence of suicide among doctors. There are a few, such as the American Foundation for Suicide Prevention, that aggregate resources addressing the problem of suicide in general. Some resources include wellness programs, physician recovery programs, American Foundation for Suicide Prevention programs, and the AMA Steps Forward program. None of these originate from an organization whose sole purpose is prevention of physician suicide. None are focused primarily on changing the practice environment that is literally torturing our doctors. Doctor Lifeline recognizes that the modern medical practice environment must be fundamentally changed if we wish to prevent physician suicides. We see opportunities to make positive changes at the levels of the individual doctor, doctors' families, institutions, and government. At the level of the individual doctor, we would like to offer helplines to offer immediate intervention and to provide confidential resources for discussing stressful issues. Ideally, we could serve as a source of referral for counseling, psychotherapy, possible psychiatric pharmacologic treatment, and interventions for acute and chronic post-traumatic stress disorder. We will provide advocacy for physicians suffering from burnout and learned helplessness. In order to assure privacy and confidentiality, we would encourage development of regional exchange programs to give the at-risk physicians the option to obtain counseling and treatment outside of their immediate communities. We would also provide human rights education in order to prevent abuse of physicians in training or those at the mercy of unsympathetic institutions. At the level of the physician's family, we will offer assistance with interventions. Understanding a burned-out doctor can be very bewildering for family members. We can provide education to family members regarding the stresses experienced by the at-risk physician and give them tips for helping the doctor to cope. Families may require counseling along with the doctor in order to optimize the home environment for recovery. The doctor's family members may require individual support, especially in the situation of a completed suicide. At the institutional level, Doctor Lifeline can help review policies to promote fairness and avoidance of abusive practices. We encourage institutions to develop a process for evaluating physicians' complaints without stigmatizing the physician. We hope to change institutional cultures to minimize workplace bullying and encourage physicians to seek help with stress, depression, and PTSD rather than suffer in silence. We can work with institutions to develop effective physician support systems. Poorly designed electronic health records are ubiquitous and currently frustrate and dishearten physicians at many institutions. Dr. Lifeline can offer advice to improve EHR design. We can offer institutions suggestions regarding assurance of confidentiality and assistance with external referrals. At the governmental level, we recommend the creation of a physician advisory board to assist well-meaning legislators and agencies in crafting legislation and regulations. We specifically wish to help them anticipate and avoid unintended consequences which add to the physician's burden and further toxify the practice environment. We wish to encourage further funding for research, intervention, and treatment programs directed at the prevention of physician suicide. We believe the government has a responsibility for investigation of serious complaints and enforcement mechanisms to facilitate a safe, non-hostile healthcare workplace environment. Fulfilling this responsibility may require a specific healthcare workplace initiative. We recommend review of state medical license board practices to minimize physicians' concerns that seeking help for depression could stigmatize the doctor and jeopardize licensing. As a 501c3 corporation, Dr. Lifeline may engage in some lobbying, but too much lobbying activity risks loss of tax-exempt status. According to the IRS, organizations such as Dr. Lifeline may involve themselves in issues of public policy without the activity being considered as lobbying. For example, such organizations may conduct educational meetings, prepare and distribute educational materials, or otherwise consider public policy issues in an educational manner without jeopardizing their tax-exempt status. Thank you for your interest in Doctor Lifeline and our mission to prevent physician suicides. You can learn more at our website, drlifeline.org. We will also be producing additional educational videos in the future. And the next time you see your doctor, say something nice, like "thank you," or "I want to tell your administration what a good job you did for me." Your kind words could save a life.